The broadcast is now starting. All attendees are in listen-only mode.
Good morning, good afternoon, good evening. Warm welcome to today's ISQua webinar on using the Virtual Quality Improvement Collaborative to improve care in U.S. Department of Veteran Affairs. This session will cover the use of the Virtual Quality Improvement Collaborative in the U.S. Department of Veterans Affairs. Attendees will learn about the evolution of the virtual collaborative model, local adaptation of the model, and lessons learned from the project designed to improve the quality of care. I'm delighted to welcome today's presenter, Lisa Zupko, who is a health science specialist at the White River Junction VTVA Medical Center and assistant professor in psychiatry at the Giselle School of Medicine at Dartmouth. Dr. Zubkov has a PhD in health services research from the Dartmouth Institute of Health Policy and Clinical Practice. Her training focused on the decision-making, policy and quality improvement. Dr. Zubkov also completed a postdoctoral fellowship at the Greater Los Angeles VA focused on the implementation science and quality of care for veterans with moderate to severe pain. Dr. Zubkov is interested in implementation of evidence-based practices and treatments, program evaluation, and quality of care. Just to remind you all that today's presentation will take approximately 45 minutes and we'll have 15 minutes at the end for any questions that you might have. You can type your questions during the presentation into the chat or question box provided, which is at the bottom of your control panel, and we will do our best to get them all answered at the end of Lisa's presentation. We will be using polls during the session, so your active involvement would be highly appreciated. Please sit back and enjoy the presentation, and over to you, Lisa.
Great, thank you very much. I'm really excited to be here and to share a little bit about our work. So as Juliana mentioned, I'm going to talk on the use of the Virtual Quality Improvement Collaborative to improve care in the U.S. Department of Veterans Affairs. So the agenda for today, for our guests roughly the next 45 minutes, is that I'm going to do a brief introduction on the Quality Improvement Collaborative and then shift to introducing the Virtual Quality Improvement Collaborative and then share some of our experiences in the U.S. Department of Veterans Affairs, and then lastly go to lessons learned in future work. So what is a quality improvement collaborative? This is a collaborative model for achieving improvement using planned change theory. It's designed to help organizations close the gap between what we know and what we do. The Quality Improvement Collaborative, sometimes referred to as QUIC, is a structured framework in which teams learn about research and best practice, applying quality improvement methods, implement small tests of change using the Plan, Do, Study, Act model, and then exchange experiences of making improvements. This model was developed by the IHI, or Institute for Healthcare Improvement. It was historically developed as a face-to-face collaborative method where teams would meet in person several times and then go back to their home facilities and make changes between those face-to-face meetings. This model, the quality improvement model, has gained increase during the last 15 years. So a little bit more information about the Quality Improvement Collaborative. It's short-term, usually roughly kind of 6 months to 15 months. It's a learning experience that brings together a large number of teams from hospitals or clinics or organizations, and it's designed to improve care in a specific topic area. For those of us in healthcare, it's usually focused on a clinical area. The model consists of 4 key elements. Those are aims, measurement, implementing changes, and testing small cycles of change, or the PDSA. So here's the PDSA cycle. Again, PDSA stands for Plan, Do, Study, Act. And when looking at this figure, we'll start in the upper right-hand corner in the plan quadrant. This is where teams set an objective and ask questions and predictions about why what is occurring. Also, the teams will plan to carry out the cycle. So they'll start planning about who, what, where, and when. And the next step will go down to the do quadrant. This is when the team will actually carry out the plan that they've identified. They'll document problems and observations that they've seen during the change. And then lastly, they start to look at the data and to do some analysis. Moving to the left is the study quadrant. This is when the team will complete the analysis of the data that they've collected and also start to compare data and summarize what's been learned. Lastly, if you move up to the act quadrant, this is when teams will look at what they've learned and start to identify what changes are to be made next. So this will help them for planning in the future. So here's the model for improvement, and this is used to help with measuring collaboratives. A successful collaborative requires teams to ask 3 questions. The first is, what are we trying to accomplish? The second is, how will we know that a change is an improvement? And the last is, what change can we make that will result in improvement? And then the PDSA that we just went over is used to help answer those 3 questions. So here is the IHI's Quality Improvement Collaborative Model. We're going to work from the left side of this figure to the right. So typically when setting up a quality improvement collaborative, the first thing to do is to select a topic. Usually again in healthcare, that's focused around a clinical topic. Once that topic's been identified, the goal is to next recruit expert faculty. This faculty is often experts in both the clinical area as well as quality improvement. Together, those folks will develop a framework and changes that teams will implement during the project. This is often referred to as a change package. Once that is completed, the next task is to enroll participants and to help them doing pre-work. Pre-work is what the teams do in order to get ready to go on the project. The next step is the square that says LS1. This is a face-to-face learning session. This is where teams come together and start to identify what it is that they're going to work on. They'll learn about quality improvement as well as to set their aims and what they will do between now and the next learning session. Between each learning session, so in this picture it's LS1, 2, and 3, teams will go home to their organization and will conduct PDSAs, trying to make changes in their home organization and make improvements. Then the folks come back together, share what they've learned, gain some new knowledge, and then go back home and do it again. During this time, there are supports to teams. Oftentimes we'll use email, phone conferences, and teams are also asked to submit monthly team reports and assessments. At the end, there'll be a summative congress where teams are able to share the work that they've accomplished and to brag about their improvements, as well as to work on final reports and publications. So I'm going to pause now. Juliana, could you pull up poll question number 1?
Sure, Lisa. I'm putting this up now. So we are launching the poll now, and as you can see on your screen, the question stands as follows. Have you participated in a quality improvement collaborative that has face-to-face meetings? You can choose between options yes and no. We will be waiting. The audience is already voting, and we will be waiting for a little bit longer. Only 30% of the audience have voted so far, so we will wait a little bit longer. %40 voted, so we do encourage all of our participants to take part. Okay, we'll give 10 more seconds before we display the results. So the results are now shared on the screen, and we can see that 42% of our participants have opted for option number 1, which is yes, and 58% for option number 2, which is no. Over to you, Lisa.
Great, thank you. I really appreciate answering that poll question. It helps to give me information about there we go, sorry, about your experience. And so what we'll do is we'll continue to go and explain about these quality improvement collaboratives. If anyone has questions as we're going through this about these, please feel free to write them in your chat box, and I'll do my best to try to address these at the end of the conversation. So I'm going to move now to talk a little bit about the literature. I felt that that was just to let people know about what's been published. So most studies examine the Quality Improvement Collaborative as a single intervention, and there's only been a few that have looked at the features of Quality Improvement Collaboratives. The literature shows mixed results. Some of the work has found positive impacts, meaning that being part of a collaborative helps teams make changes. However, there has also been literature that shows that it did not have an impact. So to delve a little bit more into the literature, there's been, even though there hasn't been quite as much literature on this, there's a growing number of studies examining these key features or components. Unfortunately, few of them have examined the influence of the various features. In 2008, Schouten and colleagues published a systematic review that found the evidence underlying the quality improvement collaboratives is positive, but the effect cannot be predicted. And they also concluded that further work is needed on the basic components, effectiveness, cost effectiveness, and the success factors.
Sorry, Lisa, for interrupting you. We can't see your PowerPoint. I'm truly sorry to interrupt you. Like, we still have the poll question displayed, so I will just try to bring your PowerPoint back. So if you can click into your PowerPoint for me and see whether we would be able to bring it back.
I'm on it.
Okay.
Explain.
Okay, so what I'm going to do now, I will try to fix it. Just give me 1 second. And I do sincerely apologize. It's just the audience can't see your slides at the moment.
No, go right ahead.
So what we're going to do. Okay, and now I will ask you to show your screen again for me, please. Bring your PowerPoint up and show your screen for me. Perfect, and just perfect. Thanks very much for that, Lisa, and I do sincerely apologize.
Not a problem, not a problem. Oh, whoops. Can you see the control panel or no?
No, we can't see the control panel. We can see literature continued. That's the slide we can see at the moment.
Fantastic, thank you. So more recently, Nadeem and colleagues in 2013 published on the components of quality improvement collaboratives. This is one of the more recent publications about this. They identified that there's 14 components as part of a quality improvement collaborative, and that the most common include in-person learning, the plan, do, study, act cycles that I talked about earlier, the use of multidisciplinary quality improvement teams, and data collection for quality improvement purposes. The general conclusion of the literature, I believe, is that more work is needed on which features are viewed as the most helpful, and then also why they're helpful, and which features are rated most highly by successful participants. So now I'm going to move to the virtual quality improvement collaborative. Juliana, can you pull up poll question number 2?
Sure, I will launch it now for you.
Thank you.
And as you can see, the poll question is now on your screens. It stands as follows. Have you participated in a virtual quality improvement collaborative where all work is done virtually? So you can select between yes and no as in the previous poll. The audience is voting actively this time, and 40% have already casted their votes. So we'll give that another couple of seconds before we display the results. Okay, and we will display the results now. As you can see that again, 44% have voted for option number 1, which is yes, and 56% voted for option number 2, which is no. So we are again pretty much even in our answer options. So I will let you to take over, Lisa, and what we're probably going to do this time, we will do it straight away with your PowerPoint because there seemed to be a glitch in the system. So I will do exactly what I have done last time, and I will let you to display your PowerPoint again if you don't mind, and I'm truly apologize for that. It just seems to be the case today. So if you can show your screen again for me. Perfect. Thank you.
You're welcome. Great. So I'm going to move on now to talk a little bit about the Virtual Quality Improvement Collaborative. So as I mentioned, IHI developed the Face-to-Face Quality Improvement Collaborative, and then in 2006, they developed a virtual version. This figure should look very similar to the previous figure I showed on quality improvement collaboratives. However, the big difference is that there are no face-to-face meetings. Instead, what you'll see here, the VLS1, these are actually virtual learning sessions. These are usually done either via phone or a web-based platform. And then between those learning sessions, teams remain at their home facility or home organization and conduct changes and then report out again on a following learning session. So again, all knowledge and teaching is done virtually, as well as the sharing among teams. The ongoing supports are slightly different in a virtual. So because it's all based virtually, there's more opportunity to use web-based platforms or emails. So oftentimes they'll use a listserv or an email distribution list so that teams, there can be both outgoing information from the organizers, but also that those participants can also email each other. There's often use of an extranet, or sometimes called a SharePoint, which is where all key documents are maintained so that any participant or participating team can access documents at their kind of own free time. There's online collaboration tools that will help teams to work together, and then the usual features such as phone conferences, monthly team reports, and then assessments. Again, at the end, there's work focused on how do you hold the gains. Of course, the goal of improvement work is not only that you make changes, but that you sustain them, and then final reports and publications. So I'm now going to turn to tell you a little bit about the work that we've done. I work with the VA's National Center for Patient Safety. And several years ago, we were looking for an improvement model to foster improvement work in the U.S. Department of Veterans Affairs. And this work was to be focused on patient safety and quality. We wanted to overcome the limitations of collaboratives and tailor to the real-world setting in the VA. Of course, we faced barriers. So we had issues around travel constraints in the VA, but more importantly, we wanted to keep clinicians at the bedside. So what we did is we adapted the IHI's virtual quality improvement collaborative model to meet the needs of improvement teams in the VA. For folks that aren't familiar with the VA, I'm just going to tell you a little bit about it so that you can understand the scope. So the Veterans Health Administration, or the VHA, is part of the U.S. Department of Veterans Affairs. The VHA, again, Veterans Health Administration, is the largest integrated healthcare system in the United States. It provides comprehensive care to more than 8.3 million veterans each year. In terms of number of facilities, there's roughly 143 medical centers, along with about 1,400 community-based outpatient centers, community living centers, veteran centers, and domiciliaries. The VA has one electronic medical record across all facilities. So if we have a veteran that seeks care in Boston during the summer months and then is a snowbird and goes to Florida for the winter, their entire record is accessible by their clinicians and providers at each VA. Obviously, because we have one electronic medical record, there are very large databases within the VA. So here is the model that we've adapted for our work in the VA. Again, this model should look very similar to the IHI's Virtual Quality Improvement Collaborative model. What's highlighted in yellow are some new features that we have integrated, those being that we've included coaching and mentoring as part of our program, as well as conducting a team questionnaire, and I'll tell you a little bit more about that. Otherwise, this model looks very similar. We have multiple calls and that are for educational purposes and for sharing of experiences, and then the teams remain at their home facility, VA facility, and are making changes during the project. So I'm going to walk you through the phases of the project. During the pre-phase, this is when the teams are kind of getting organized and ready. This typically for our work lasts about 2 to 3 months. And the tasks during the pre-phase are the teams are to develop a multidisciplinary team and to start meeting. They'll secure leadership support. They'll collect and analyze baseline data. For our work, we typically request that teams look back at least 6 months, preferably a year, to look at trends in their both their process and their outcomes data. We ask teams to review the evidence as well as to flowchart their current process in hopes that they'll identify processes that need improvement. Based on all of that, the last thing is that we ask teams to develop an aim statement. And this picture here reminds me about teamwork as teamwork is getting started. I hope you all can see it, but if not, there's a animal on the bottom that is carrying multiple smaller animals, and that we get the report from folks as they're just starting that it often feels like they're carrying a lot of weight on their back as they get going. So I like this picture for that reason. So the next phase is the action phase. This lasts roughly 6 months. During this team, the teams are tasked with continued meeting to implement changes based on the aims that they've identified in the pre-work. They track progress both in processes and outcomes, and then they submit a monthly report. When this report is submitted, they'll receive feedback from the coaches that they have assigned to their teams. They develop a spread and or sustainability plan and then submit an end of action report. Here's another picture that makes me think about teamwork. As you'll see, these two dogs have a common goal. I think those are cheeseburgers or burgers or something on the counter, and that they recognize they had a common goal. And then what they did is they worked together, recognizing each other's strengths and weaknesses to make it to the counter for the good food. So the continuous improvement phase, again, this lasts 6 months as well. This is when the teams have completed trying to make the changes that were identified to meet their goals. We ask the teams continue to meet and that they work on the goals set in the action phase, and then that they start to think about spreading changes to other units within the organization. They continue to track data, both on processes and outcomes, and then submit a final report. So as I mentioned, there's a few key features that we've added to our work, one of which is a team questionnaire. So this is a validated questionnaire that was developed by some of my colleagues that asks teams about prior work together, leadership support, and available resources. The response options range from 1 being strongly disagree to 7 strongly agree. Teams are to complete this together, so 1 questionnaire per team, and it's completed pre-post. And then what we do is we compare the mean scores at baseline, which is the pre, or the follow-up, which is the post, to determine if there are any changes in their responses. So teams are asked to submit their initial team plans. This is very brief, but it helps us to understand where the teams are starting from. We obviously want to know who is the team, who are the team members, what do they do at your facility or organization. We'd like a brief description of the organization, and if this project is on only 1 unit within an organization, a hospital or clinic, we like to know where they're focusing. They'll work on setting their aims, and then they submit some summary, usually a run chart of some sort, on their baseline findings. So the team reports, after they're up and going during the action phase, teams are going to submit a monthly report. This provides information on updates, progress, the process changes that they've made during the prior 30 days, as well as display data and the challenges that they have faced. We ask for the challenges so that as we provide coaching, it helps us to focus our efforts. Coaching. So as I mentioned, this is something that we've added to our model. There's prior research that suggests that that coaching can add value in a quality improvement collaborative. Gustafson and colleagues published a study showing that coaching in and of itself actually had a greater impact than being in the collaborative itself. So building on that finding, which we felt was really important, we added coaching as a key component. So I'm going to explain a little bit about coaching. So the structure of our coaching is that there is a quality improvement coach and a clinical coach, and they're paired up to kind of work together. That pair then is assigned to coach 6 to 8 similar units. There are structured interactions for the coaches with their teams. However, we have an open door policy and the coaches are available as needed. So the QI coaches focus on a few things. First of all, they initiate contact with the teams and they serve as the primary contact during the project. They coach on quality improvement tools and methods and goals of helping teams to make frontline changes to improve. So they'll focus their work on setting aims, process mapping, and so on. They review the team progress and offer specific written feedback based on the accomplishments or lack thereof if that it is encountered. They're there to problem solve new issues or concerns that arise during the project. And one of the most important features or things that they do is that they create a culture of shared learning. Our goal as coaches is to help the team succeed. This is not to be viewed as a reporting mechanism solely, but that rather we have a common goal. So the clinical coaches, they are often experts in whichever clinical topic area the project is focusing. So they focus on the evidence base of the interventions that the teams are implementing. They often address key clinical issues that may impede making changes to care processes. They'll share knowledge on work that they are conducting as well as colleagues, and then they also will share the work of other clinical teams. They provide additional feedback on the monthly reports as well. So one of the most important things to think about is how will we know that a change is an improvement? So what we do is that we track both process measures and outcome measures. So for process measures, examples of these might include implementing the use of a post-fall huddle when working on falls prevention, or similarly to order or use specialty equipment for veterans that may be having issues perhaps getting out of bed or needing a walker. We also will measure patient satisfaction as a process measure. So the outcome measures are tracked to assess the patient impact. Examples of these might be when working on falls prevention, the fall rate, or the fall rate with injury. Another example in a different clinical topic area would be the percent of patients who developed a pressure ulcer in a given month. Can we do poll question number 3, please?
Sure, Lisa, I will launch it now for you.
Thanks.
And it's now launched. As you can see, it stands as follows. Would a virtual quality improvement collaborative help you to make improvements in your organization? So you can select between the following options. No, it would not be helpful. Not sure if it would be helpful. And yes, it would be helpful. So we kindly ask our participants to start voting. And I can see that the options are divided between 2 and 3. Nobody has voted for the option number 1. No, it would not be helpful at all. Not yet, anyway. So we will just wait a couple of more seconds before we display the results. Okay, and the results are shared on the screen now. 5%, I would rather say that the people that didn't vote, but it could be that somebody voted no, it would not be helpful at all. So 38% voted not sure if it would be helpful, and 57% yes, it would be helpful. So I will, you can take over, Lisa, and we will do the same trick again as we have done last time, and quickly do that again. It seemed to be an issue today. So if you can just show my screen, click show my screen for me.
Did it work?
Yes, it did. And if you can just click slideshow or F5.
Is it displayed?
Perfect. It's we can see slide poll question number 3. Thank you, Lisa, and please do accept my apologies for this glitch.
Not a problem at all. Thank you. Well, I'm really excited to hear that 95% that kind of voted in the maybe or yes. That's music to my ears. I'm really excited to hear that 57% said yes. It's this is the type of work I do, but it's nice to hear that folks in the field are feeling like this may be a quality improvement method that could help them. So that's great news. I'm going to now turn the conversation to share with you a little bit about the work that we've done in the VA. So here are 3 projects that we've worked on over the last several years, and I want to present those to you about what we learned in each project, thus far. So first, we focused on falls and fall-related injuries. Second, we've done some work around the prevention of postoperative respiratory failure. And then lastly, the prevention of catheter-associated urinary tract infections, or CAUTI. So for the Falls project, we had 59 teams around the United States that work in the VA who participated in our project. Among the 59 teams, 53 unique interventions were implemented by those teams. The average number of interventions was 6.4, but it ranged from 1 to 12. So that means that at least one team only implemented one intervention, and at the other end there was at least one team that implemented 12. The mode of interventions was 6. So the interventions were grouped by pre-identified domains. We had 18 of those. Some examples include working on having a safer environment or modifying patient-specific fall risk factors. Another domain was some type of implementation focused on injury risk reduction. So the remaining interventions that teams implemented were grouped into 2 categories. Those interventions that we expected but did not fall into our domains, and then the remaining went into an unexpected or miscellaneous grouping. We did questionnaires. So we had the team questionnaire that I described earlier. For this project, there was also a self-assessment questionnaire that was conducted pre and post as well. This questionnaire was designed to help teams look at the processes or the program that they have currently for falls prevention, and then it will help them to identify other interventions that they might consider. For outcomes, as I mentioned earlier, the VA has a lot of data. One of those data sources is the VA's Inpatient Evaluation Center called IPEC. And for that database, all VA facilities are encouraged to submit their fall rate and their fall-related major injury rate every month. So we went to that database in order to pull those outcomes. So I'm going to share with you a little bit of the results from the project. So for the questionnaires, the self-assessment questionnaire was designed where you were scored from 0 to 189. The higher the number, the better the score. And what we found when we compared the pre and post was that the average summary score improved from baseline to follow-up. When we looked at the team questionnaire pre-post, we found there were 4 items on the questionnaire that improved. And this is about agreement with the following statements. The team had a shared vision of how to improve. The team had a good way of solving conflicts, had a specific plan to spread the information, and that the changes they're making was supported by frontline staff. So the way to interpret this is that they felt they had more agreement with these statements at the end of the project than they did at the beginning. So the outcomes, as I mentioned, there were 59 teams in this project. However, some teams represented more than one unit. So as such, we had 72 participating units that were included for our outcomes analysis. These participating units were also compared to all other non-participating units that submitted the data, and that was 291. So when we looked at the fall rate, that did not change significantly from baseline to follow-up for participants or for non-participants. So that stayed the same for both groups. However, we found that for participants, there was a significant improvement in the fall-related major injury rate. And again, that's for participants. However, we did not find that same finding for the non-participating sites. Again, that's for the 291. I realize this is a lot of words, so I'm going to show you this in a graph so that it will help to explain. So the blue line at the bottom is the fall rate for the participating teams. The green line just above it is the fall rate for non-participants. And as I said on the previous slide, there were no significant changes in this. However, the red line that starts at 6.8 dropped significantly, statistically significantly, to 4.8 during this project. And then lastly, the purple line depicts the major fall rate for the non-participating teams, which did not change. So the only change that we found during this project is the red line, which was major fall rates. So the second project was focused around preventing postoperative respiratory failure. This was a smaller project. There were 16 VA teams that were part of this project. Some of the examples of interventions that they worked on were improved use of incentive spirometry, improved oral care, standardizing orders, ambulation of patients post-surgery, and provider education. We did the team questionnaire again pre-post, and for outcomes we looked at two VA data sources. One is the ISQua program, which is a surgical quality improvement program. And in this database, we looked at the incident rates of failure to wean, pneumonia, and reintubation. And then in the IPEC database, which is the same database that we use for falls, we looked at the ventilator-associated pneumonia infection rates. So the results. We had interesting results for this project on the team questionnaire. We actually found that one of the items got worse, meaning that the teams agreed less with the statement that virtual breakthrough series is part of our organization's strategic goals. I'm not surprised by this finding because oftentimes teams will start on a project that they believe is a priority, but when they start to make changes, they realize that they may not have the support that they need. So of our outcomes, there was only one outcome that significantly improved when we compared during the project, and that was failure to wean was lower after the collaborative, and that was statistically significant. So the last project I'm going to tell you about is the project focused on prevention of hospital-acquired conditions, specifically CAUTI. So there were 18 teams in this project, again, all based in the VA. They worked on or implemented 33 unique interventions. Some of the most common interventions that were worked on were focused on staff education, improved documentation, or routine review of patients with catheters to assess the continued need for that catheter. We did our team questionnaire and then our outcomes, and on this project we looked at both participating teams and non-participating teams, and our focus was on the CAUTI rate. So the results. So there was only one questionnaire item from the team questionnaire that changed significantly. And as we had in the previous project I described to you, the score actually decreased, which means that the team agrees with this statement less at the end of the project than they did at the beginning. And the item is that the team has sufficient resources to meet their aims. And as I said with the previous project, we've found that sometimes teams believe that they have the resources that they need, but then when it comes to perhaps ordering new supplies or something other like that, they don't feel that they have the support that they need. The outcomes. So for participating units, the CAUTI rate decreased from 2.3 to 1.06. And so lower is better for CAUTI rates. And this was a statistically significant improvement. However, for all the other non-participating sites, the CAUTI rate did not change between the phases of the project. So that suggests that participation may have assisted with the CAUTI rate. However, we recognize that we don't know what else teams may have been doing or sites may have been doing, and there may be other things that are contributing to this decrease. So here again is a visual. The non-participants is the blue line, showing obviously that there was no change. However, the red line shows that between the pre-work and the action phase, there was a significant decrease in CAUTI rates, and then that rate was maintained into the continuous improvement phase. Lessons learned and future work. So now that we've done a couple of projects, we'd like to spend a little time kind of reflecting on what we've learned and what we need to do in the future. So there are several lessons learned. The first is that making change is hard. We know that. However, our work shows that it is possible, which is exciting news to us. We've learned that standardized measurement for primary outcomes is important when assessing changes over time. We in the VA are very fortunate that we have a lot of data. However, for one of our projects, we did not have standardized measurement, and we attempted to collect outcome data manually, and we found it to be very labor-intensive and less reliable. So we recognize in our virtual work that we've eliminated face-to-face meetings, and we do wonder whether or not there's been a loss of personal connection, which may reduce the ease that participants share ideas with each other. There is a support and a connection that happens when you meet face-to-face, and we recognize that that may affect sharing and participation as well. We've learned that interventions need to be clear and simple. The scope of work that teams focused on varied greatly depending upon the precision of the interventions. So for interventions that were not clear as to what should be done, the teams really struggled with making those changes during their projects. And lastly, we believe that coaching may be a key ingredient for success. We've only done limited evaluation on this, but we do plan for a more robust examination into the effect of coaching on team success. We believe that this may have an effect, but of course future work is needed. So leading into our future work, we have a couple of goals that we hope for us moving forward. First, we'd like to spread our work to other clinical areas in the VA. As I mentioned, our work mostly focuses on safety and quality. However, there's many clinical areas that we could address. We're trying to learn about if there are differences between clinical areas. We'd be very excited to collaborate with non-VA entities to learn about the barriers that other organizations face. We've learned a bit about what the barriers are for VA quality improvement teams, but we're not sure if what we're learning are the same barriers outside the VA. Similarly, we'd like to expand the generalizability of our work. It would be fantastic for us to know that our work could apply to other settings, both within the U.S. and internationally. We'd also like to tease out the impact of coaching vis-a-vis the impact of being in the collaborative. So we are finding data that supports that being in a collaborative is helping with improvement. However, we haven't been able yet to figure out, is that just from being in the collaborative, or does coaching play a key role? Lastly, we'd like to look at the sustainability of improvements. We've done some limited work about sustainability. It looks like teams are sustaining their changes, but we really hope to identify a plan to move from doing PDSAs to SDSAs, which is more about standardizing, do, study, and act. And our goal is that this will help to sustain the changes in the process, as that really is the overall goal of improvement work, is not only to make changes, but to sustain them over time. So here are some references that I've included for those of you that are interested in any of the literature that I've cited. And with that, I'm going to ask for questions, and thank you so much for this opportunity to present to you. I really look forward to questions, feedback, or thoughts as we wrap up. Again, thank you so much.
Thank you so much, Letha, for this very interesting presentation. And we do indeed have a couple of questions already. And I'd like to thank you for sharing the lessons learned, which I hope our participants would be able to learn from as well. So the first question is there are a number of questions in this, and it's coming from Omar Zaman Sayedi from Afghanistan. He's asking, is the collaborative quality improvement initiative, um, just let me just see, he's asking, is the collaborative quality improvement initiative a self-starting process or organized by a third party? Do the teams, are the teams made up of members from more than one organizations, or is it just one organization? It looks like this is a voluntary process. Does it work if this would be a voluntary process or if there is a lack of resources to organize the initiative? And in summary, what are the successes and failures of this initiative? So there are a number of questions, and I'm happy to get through them again if you wish.
Let me try to take a stab at it, and if I miss something, please let me know. So the first question is kind of who organizes it, I think. So as I mentioned, I work for the National Center for Patient Safety. We are the organizers. What we do typically is we put out an invitation to participate, and then the teams identify and apply. We actually are encountered with the fact most of our collaboratives that we have more teams that apply than what we can actually handle. And the rate limiting factor in the number that can participate is the coaching. Because this is very labor intensive and requires our resources, we have to have coaches. We can't always accept everybody at the start of a project. So the VA teams, this is all work done within the VHA or the VA. So these are teams at VA facilities around the United States, and they, again, are the ones that are participating and applying. The last is voluntary versus involuntary. I did just say that usually it's that teams apply voluntarily. However, there was one project where it was recommended by the chief of that clinical area, and we did feel that there was a slightly different attitude around kind of being recommended to do it and self-selecting to be in the process. However, that said, we found positive outcomes in that project as well.
Thank you, Lisa. One more, I think, that was part of this question is, in summary, what are the successes and failure factors of this initiative?
Ooh, that's a big question. So the successes are that we're showing that teams are making improvements in outcomes. It's not every outcome, but teams are actually improving. In my opinion, the most success that we see is that teams are actually implementing new evidence-based practices that weren't in place before. And that really is for an outcome, although it's a process outcome, that's one of our bragging rights. That said, too, I think that one of the other successes is our coaching. We're really having an impact in terms of helping teams to achieve success that has not been part of other collaboratives, and we're quite proud of that work.
Thank you, Lisa. The next question is from Patricia McKernan, and she's thanking you for a very interesting presentation. She's asking, did the teams have any insight into the reason for a decrease in major falls? and not for all falls? Was the same fall risk assessment and interventions used across all sites? Was this trend uniform across all participating sites? She says.
Okay, well, you may have to repeat questions again
Yep.
as well. But the teams, so the first thing is that when we make these comparisons, they're done in aggregate. So it is a trend across all sites. For any changes that we detect, again, it is aggregate for all sites. The first question, I'm now forgetting.
Yeah. So did the teams have any insight into the reason for a decrease in major falls and not for all falls?
So I think that part of it is the work that we did. We stress that falls are important. However, that depending upon the setting, that major injury was actually even as much of a priority. We had teams that selected to only focus on reducing major injury. We did not tell them they had to focus on both. And the reason why is that their data should drive the interventions and the focus of their work. And we found that there were a handful of teams that decided to solely focus on that. Now, that may have had an impact, but I'm not sure.
Perfect. And one of the other questions was in this long question as well, was the same fall risk assessment and intervention used across all sites. So I suppose this is to
Yep.
achieve the integrity. Yep.
Yeah, so the assessment is the same. I think you're talking about the injurious risk assessment, a questionnaire. That was the same across all sites. The interventions we do as part of developing the change package is that we provide a list of evidence-based interventions. However, we do not force all teams to do exactly the same thing. So again, data should drive what they work on. For some, it may be something like the post-fall huddle, whereas the other may identify that what they actually need are specialty beds, like a lower bed. So the data was to drive what teams worked on. That said, we did provide a menu of evidence-based interventions, and the coaches were tasked with helping to make sure that the appropriate interventions were what the teams were focusing on.
Thank you, Lisa. The next question is from Kalada Richard from Nigeria. And he's asking, in implementing the collaborative, did you have any issues with some things that lagged behind, like failure to carry out the processes for the change improvement?
Sure. Yeah, we did. There are teams that struggle in all improvement work. And that's one of the reasons why we feel coaching is so important. So that when we found that certain teams were lagging, that we would ramp up the coaching. And that's really the coach's responsibility, is to figure out, have they identified a name and are they doing something about it? If they aren't, then we ramp up our resources, and as I mentioned, we're kind of available, the coaches are available as needed, and so we would oftentimes schedule additional calls with those teams, and sometimes we found out that it could be a personnel issue or a staffing issue. One team I remember, one of the key team members went out on medical leave. And the project lagged because of that. And it took having kind of that additional conversation to learn that was occurring, and then to help them to brainstorm what could they do in the meantime to try to compensate for that issue.
Thank you, Lisa. The next question is, how is your team managing sustaining improvements?
So our team, does it say our team or the teams that are participating?
Your team.
Yeah. So we're trying. That's the real honest question. We have currently been measuring, depending, about 6 months or 1 year out from the end of kind of the action phase to look at sustainability. This is an area that we'd actually like to do more work on, but to go back and look perhaps 2 years out or 3 years out to determine if the outcomes remain the same. We have yet to do that, and that's why that's one of our next step areas that I identified. So it's a work in progress for us.
Thank you, Lisa. And a number of participants are asking whether you would be able to share your team questionnaire, and basically they're looking
Sure.
to.
Yes, I do not have my email on here, but if somebody is able to contact me, or I can give it to you and you could post it, I would be happy to do so.
Yeah, what I can do, if you can forward it on to me, and I'll share the resource kind of for the participants that are attending this webinar and for the participants that are going to watch the recording of this session as well.
Okay, the other thing that you can also look at, I believe this questionnaire may be an appendix in the reference. Let me go back if you go back one to here, let me pull this up. It's the Mills, it's reference number 16. It may be included in that as an appendix. So just in case if it's slow or difficult for you to get it, I'd check there. If not, I'm happy to share my email and you can reach out to me directly.
Thank you so much, Lisa. I think that's all we have time for today. Thank you for this brilliant presentation, and I would like to thank our audience for attending the session and finding time to join us and enjoy the presentation and the lesson, and to share and get to know the lessons that you have learned from implementing this initiative. So just to remind everybody that the recording of this webinar will be available on the ISQua website within the 24 hours. So if you know anybody who would be interested to find out information from this webinar, it will be freely available to them. And I would like to thank everybody again and wish everybody a good day or good night. It's still a full day of work ahead of Lisa, and for some it could be a bedtime, but thank you everybody for attending and Lisa for presenting.
Thank you so much for having me.